All right, good morning, everyone. I'm going to go ahead and get started. My name is Jeff McMahon. I'm one of the second-year residents here, and I'll be presenting today's first case. So our first case this morning involves an 11-year-old boy. He comes into clinic complaining of spots in both eyes. He says that for the past 2 weeks, he's been noticing bluish-colored dots with a black background, more so in the left eye than in the right. They resolve spontaneously over a period of days. Otherwise, he denies headaches, pain with extraocular movements, recent illness or trauma. He has no past ocular history, no known drug allergies. His medical history is unremarkable. And in terms of his family history, his paternal history is limited, but according to his mother, both the father and aunt on his paternal side have a diagnosis of sarcoidosis. His maternal history is otherwise unremarkable. In terms of his social history, he does report that he's having difficulty with school assignments, having trouble seeing the board despite sitting near the front of the classroom. His review of systems is otherwise unremarkable. So on exam, best corrected visual acuity, 20/40 in the right eye, 2200 in the left. Pupils are equal, reactive without an afferent pupillary defect. Pressures are normal. Confrontational fields are grossly full. His color plates are full as well, and his extraocular motility is full. So in addition, his slit lamp exam is unremarkable on initial presentation, which brings me to my first set of fundus photos. And here we have a montage. Dr. Haller, do you mind commenting?
He has a yellowy appearing macula, which looks a little more yellow than we'd expect. I mean, especially in kids. How old is he again?
He's 11.
11, yeah. So sometimes you can be a little fooled if you're used to looking at older fundi by the very bright reflex off the back of the eye. And then in the periphery, it looks like he's got this stippled pigmentation with some actual pigmentation, some hypopigmentation, and then hyperpigmentation.
Great. And here we have the left eye.
And the macula on the left looks similar, very yellowy gold appearance, and then in the periphery, more of this dotted hypopigmentation and overall modeling of the pigment with some kind of maybe early bone spicule type change.
There's also, Jeff, I think, see how the internal limiting membrane is all broken up here? In children, my mentor taught me that's one of the earliest signs of sometimes of retinal changes in a kid. Instead of looking, if you'll excuse a Canadian analogy, instead of looking like an ice skating rink after the Zamboni came across it, it looks like people have been skating on it, right? And you get this kind of broken up reflex.
Right.
You said that's an early sign of what?
Of retinal dystrophies.
So Dr. Heller, at this point, any additional testing you would be interested in seeing? What would be your next step moving forward?
Well, it would be interesting, talking to my coffee cup, it would be interesting to see what the OCT looked like. Be interesting to look at a fluorescein angiogram and then electrophysiologic testing visual fields.
Great. Okay. So we have our OCT first. Sure. And Dr. Vander, do you mind commenting on our OCT here?
Sure. We have a significant elevation with loss of the foveal depression in each eye. We have a large number of dark intraretinal spaces, seen better in the left eye, and then this very substantial darkness with these fine septi running across. So perhaps not full thickness elevation of the retina, but a schisis type arrangement. It looks like there may be, it's tough to tell from this view, there may be the ISOS intact underneath.
Okay, great. Does this add anything to your current picture?
We're seeing here sort of a stellate pattern in the right eye and maybe a little less prominently in the left eye, going along with the schisis suggestion that we saw in the OCT.
All right. And lastly, here we have just an early and late frame on the fluorescein angiogram.
And not surprisingly, we're not seeing any significant abnormality on the fluorescein angiogram.
Really no leakage, right?
Right.
Yeah, why is there no leakage? Does anybody really know why we don't get leakage with this condition?
Well, you could step back and say, what is the cause of the condition? Because it's not vascular incompetence creating those cavities. What is the cause? Maybe Alex will tell us.
I think in general, when we have leaking intraretinal spaces or cysts, we are seeing vascular incompetence, so we're seeing the vessels leaking or the fluoresceins going in, as opposed to these other disorders in which the problem is that the retina can't stay together, right? So the retina is not, schisis is a bad word, the retina is coming apart, so to speak, and those black spaces are filled with fluid.
Okay, so this is not active leaking. This is more like a passive,
The retina's coming
Anatomically-
apart like Swiss cheese.
yeah.
All right, so moving forward, we have visual fields here. Dr. Pro, would you mind commenting here on visual fields?
You know, I actually don't have much to say about the Goldman fields, and sometimes we obviously don't use them too often. I mean, it would look to, I would think to say it looks a little bit constricted, but I'm not really so sure.
Okay.
The automated Goldman too, isn't it? Which
Right.
we really don't, I don't think put much faith in.
Well, we stopped using the automated visual field in the last couple of years. It's really unreliable. The patient hears the click, so that it's
Right.
falsely better than it usually is. We're waiting to establish the gold standard, which is manual Goldman visual field testing. That's the best for these patients.
All right, and lastly, we do have an ERG, essentially showing an abnormal full field with both rod and cone dysfunction, and a severely abnormal multifocal ERG in both eyes, which we can see here. So, Dr. Levin, with what we have, patient comes into your clinic, we have this information. What's on your differential at this point?
So sure looks like a retinal dystrophy from the clinical findings to the ERG. No other stuff going on systemically. So when we approach a retinal dystrophy as a general diagnosis in a kid, we look for clues, and the cysts are a clue, the intraretinal cystoid spaces. There are several specific genes which we know are associated with that, but that list is actually growing as well, so not enough to pinpoint one diagnosis.
All right. So again, hereditary causes certainly near the top. Just to step aside briefly, we have a paper published by Dr. Levin and colleagues looking at macular cystoid spaces in patients with retinal dystrophy. This was a review retrospectively of 18 patients, finding that they can occur, as you mentioned, in a variety of dystrophies: choroideremia, Goldman-Farb, X-linked retinoschisis, Usher syndrome, to name a few. In the review, therapy and prior studies as well, therapy with topical or systemic carbonic anhydrase inhibitors has been variably effective for treating patients with non-leaking macular cystoid space. In this study, I believe 71% of patients improved in terms of their visual acuity. Of those 71%, 60% had a corresponding decrease in foveolar thickness, so there's not necessarily a concordance there. And to go back to our patient does undergo initial genetic testing looking for gene mutations in the X-linked retinoschisin gene as well as NR2E3 associated with Goldman-Farb. These return negative. Dr. Levin, how do you interpret these results? What else might you be looking for at this point?
First of all, it's important to understand the situation. So this is a patient whose insurance did not cover testing, and therefore we were left with certain options. There was at the time enrollment in the iGene work at the NEI, in which case the genes are actually selected for you based on the phenotype, so we don't have as much control over the testing. And based on the information we provided them, they chose these genes. Usually we choose the genes, and we prefer to do that. But these were pretty good choices. There are features of X-linked retinoschisis, although not classical in the OCT. NR2E3, which causes a variety of disorders, enhanced S-cone, Goldman-Favre, and some others, is one of the well-noted things associated with intraretinal cystoid spaces. They come back negative, but negative doesn't always mean negative. It simply means that whatever test they did didn't show an abnormality. So we need to know, did they do full sequencing? Did they look deep into the introns? But for the time being, let's just assume that there are no recognizable abnormalities that we believe have been thoroughly investigated for these genes.
Great.
Alex, can we go back one? What percent of patients with X-linked retinoschisis have XLRS1?
So it's a bit of a trick question because you have to
I'm always
know
trying to
that
trick you.
You have to know the patient really has the phenotype. So one of the reasons for a negative test is that you have the wrong phenotype, the wrong diagnosis. So a test can be negative because technically they didn't look everywhere. It could be negative because you have the wrong diagnosis, or it could be negative because you have the right diagnosis and the wrong gene. We only have one gene for juvenile X-linked retinoschisis, and this patient does not have a lot of features. Those white dots in the periphery you can see in juvenile X-linked retinoschisis. Pigmentation changes are odd in that, so he's not a great match, and his ERG doesn't show the typical schitic pattern that we see on X-linked retinoschisis. So probably not the diagnosis, therefore not going to pursue that further.
Did we look at family members?
So the family members, unfortunately, the father was not available to be examined. The mother was unremarkable. And moving forward, Dr. Levin, how do you consider whether or not to use topical versus systemic carbonic anhydrase inhibitor therapy in these patients?
We always start with topical. It's easy, twice a day, no systemic effects. And then based on that, in every visit we ask 4 questions. Are you subjectively seeing better? Are you objectively seeing better? Is your OCT qualitatively better? And is your OCT quantitatively better? And our study shows that those 4 things don't necessarily correlate with each other.
Alex, are there any studies that discuss the penetration of topical CAIs? It's just hard for me to imagine that a drop twice a day is going to achieve any significant levels back in the retina where this process is taking place, and yet clinically you see a response. Is that the drug works at very low doses, or you're just getting a random effect?
So no one's looked biochemically, at the retina, but we know clinically, especially initial studies where juvenile X-linked retinoschisis, there's no question that it works in some patients. We also know, interestingly, in glaucoma, that kids, unlike adults, have an additive effect of topical and oral carbonic anhydrase. They have a juicier carbonic anhydrase enzyme in their retina, so there's more opportunity. So kids may actually be more receptive to lower doses, but we know it works. I mean, clinically, there's just no question.
Do you use Trusopt or Cosopt?
Well, Cosopt has a drug that would be not effective in it. It's got a beta blocker, so we just use dorzolamide. You can also, some people have used dorzolamide as well.
Great. So our patient is started on systemic carbonic anhydrase inhibitor with initial improvement in visual acuity. If I recall, I think his left eye ended up improving 2200 down to 2080 range without necessarily a corresponding improvement in the OCT. The right eye improved 1 or 2 lines on the Snellen chart. So as our story unfolds, the patient is lost to follow-up. He presents 2 years later to the Wills Eye emergency room. And at this point, he's complaining of pain, photophobia, and redness in both eyes that have been getting progressively worse. So at this time, his examination is remarkable for moderate conjunctival injection. He has 2+ AC reaction in both eyes, as well as 1+ vitreous cell and mild vitreous haze. No pars planitis or snowbanking was noted on this exam. And here we have, after being started on topical corticosteroid therapy, the patient comes in to see us in clinic. I apologize, I think the photos are a little bit blurry, but Dr. Haller, does this look markedly different? Any comments here?
Well, I was going to say I thought he had some inflammation. Maybe that's why the pictures were a little bit out of focus. But he's it looks like he's a little bit different in terms of some of the pigmentation. Like it looks like there's some spots over on in the left eye.
You agree there's some vascular attenuation, Julia?
Yeah, I would buy that.
All right, so we have an OCT here at this point. And moving forward, we also have a fluorescein angiography. Dr. Dunn, would you mind commenting on what you're seeing here?
So now the angiogram has changed substantially. So in both eyes, you see staining of the disc, and you also see some vascular leakage out there with staining particularly in the left eye.
Still no.
But there's still no, yeah, exactly. There's still no CME.
All right.
And the CME is better in the Schisis is better in the left fovea.
It was at that time. So, Dr. Levin, at this point now, are we looking at two different disorders? What are you thinking about?
I think you'll talk a little bit more about uveitis in kids who have retinal dystrophy. I think he's presented initially with a retinal dystrophy of some sort. When we see uveitis, the question is it related or is it not? So we have to entertain both possibilities. When we put it with a retinal dystrophy, the differential gets very narrow very fast. When we put it without, then it's as broad can be. You're allowed to get two diseases.
All right, so obviously pursuing etiologies related to his new inflammatory response here. We did add a couple of diagnoses under the hereditary disorders, trying to link potentially both diagnoses, and I'll go into Coates-like retinal dystrophy and ADNIV, or autosomal dominant neovascular inflammatory vitreoretinopathy as well. Those diagnoses are entertained. So our patient undergoes a workup, and essentially, unremarkable, he has a mildly elevated angiotensin converting enzyme.
You have to adjust the ACE for the age of the child. So pediatric angiotensin converting enzyme levels are different from adults. That's probably not dose adjusted, and that's probably perfectly normal for him at that age.
Right, and imaging was normal as well. So, briefly, to step aside again, a little bit more about ADNIV. This was a disorder characterized by Dr. Bennett initially in 1989. He looked at 28 affected members of a 61-member family found to be affected with a previously uncharacterized inflammatory syndrome. He essentially divided this into 5 stages and noted that throughout all 5 stages, there is a progressive retinal degeneration that occurs with pigment clumping and progressive visual field loss, essentially breaking stages down into stage 1 with vitreous cell, abnormal ERGs. Patients would then progress to develop either cataract, macular edema, or optic disc edema that diminished visual acuity. And then they would develop proliferative retinal neovascularization that could lead to tractional retinal detachment. In this condition, prognosis is poor, and many eyes went on to become Tysical. And more recently, we have a second study. This was published actually last month in Ophthalmology, looking at retinal dystrophy in 6 patients who presented with intermediate uveitis. These patients aged range from 12 to 22 on initial presentation. So all patients were found to have non-leaking macular cysts by OCT. They had visual fields that were obviously abnormal, and patients were initially diagnosed with an idiopathic intermediate uveitis after their workup returned back normal, and essentially moving forward, they were started on topical therapy for the macular cysts, as well as periocular or intraocular steroid therapy without resolution of the inflammation or the macular cystoid spaces. Systemic medications are listed there. Within a follow-up period of 1 to 8 years, patients eventually had an ERG that was found to be severely abnormal, diagnosed with a retinal dystrophy, and found eventually to have a corresponding genetic mutation as listed.
You'll notice that 1, 2, 3, half this population is CRB1, which is interesting.
Right. So going back to our case, our patient comes in, he's treated initially topically without resolution of the inflammatory response. He does receive subtenon's Kenalog injections, and he has an initial improvement in visual acuity, as well as initial improvement with the macular cystoid spaces. Dr. Levin, what are your thoughts on, how you gauge response here, what your options for treatment are?
So I thought this guy had ADNIV was my first diagnosis. Very rare disorder, terrible prognosis, very aggressive, and your only hope is aggressive treatment. So that's why we went to subtenon's injections as our first try. Obviously, it avoids the risks of long-term steroids. I think he had a course of oral steroids too. It showed some improvement. So obviously, we got some effect on the retinal side, on the vasculitis side. And that's one good diagnosis to put the two things together. CRB1 is another gene that puts these things together to some degree, although he doesn't really have pars planitis. The fluorescein in CRB1 is different than what he has, though. They tend to have perivascular sparing initially, and then later this Coates-like phenomena really looks like Coates with an exudative response, which he doesn't have. So he's not fitting, and he doesn't have neovascularization, so he doesn't really fit neatly into any category. So at this point in time, I'm thinking, let's treat this apparent vasculitis or retinal inflammation because that's our biggest danger. Jamie, do you have any thoughts? JP?
Well, if this kid has adniv, and then I see one more, that'll be two that I've seen in my lifetime. So I'm certainly deferring to you on this.
In general, treating what may be a retinal vasculitis, what's your approach, your stepwise approach?
I typically start with steroids and then quickly go to a steroid modulating agent, an immunomodulatory agent like methotrexate. Again, as you saw, some of the biologics have been used, and there's absolutely no data on, any convincing data on how effective these are. But the principle is just, you obviously want to use a steroid-sparing agent in anyone who's going to be on therapy for a long time, and particularly in a child, to avoid the multiple side effects of systemic steroids.
Can we see the fluorescein angiogram again?
Sure.
Yeah, it's just, it's puzzling to the absence of leakage now if we're postulating the vision loss is in any way due to an inflammatory condition, to see what the mechanism is. I guess it could be optic neuropathy. But there is still no leakage in the central macula. And is there a VEGF component here? Would one contemplate an intravitreal injection of that? Maybe. I don't think anybody would know. Has zero experience.
I think this kid definitely has a retinal dystrophy. I mean, remember, he had visual loss before any of this, right?
Right.
So he had his intraretinal cystoid spaces, he had a retinal dystrophy. So I think we have an explanation for his vision, which didn't actually get worse during this phase. This is like a peripheral finding. And we did consider injections. That's why I sent him to JP to think about which way to go after we got no lasting deep effect from his subtenon steroids.
The other option would be peripheral panretinal photocoagulation, if we're fearing impending neovascularization, which you could wait and see if it forms and then treat, but not wait too long.
All right, so moving forward, our patient does undergo, apologize for all the slides here, our patient does undergo additional genetic testing, and this also, so he's tested for the vitreoretinopathy SMART panel as well as CAP-N5, which is associated with ADNIV. These tests also return initially negative, with deletion and duplication studies pending for the CAP-N5.
And just as, we talked about negative tests before, a test can be negative if you're sequencing a gene that isn't there. So one of the things you have to do, if you really think your phenotype may be correct, then you have to go and do deletion duplication, because that's not picked up on screening. So that's kind of the last step to rule out the gene other than deep intronic sequencing.
All right. So at this point, Dr. Levin, additional testing you would be interested in ordering, and Dr. Dunn, what are our options moving forward?
So I think this patient's going to turn out to have a CRB1 mutation, and that's our next step, and that's pending at this time, being done in Iowa for us. This is one of those situations where we don't have a broad panel of genes to do. We're kind of down to one gene, what's the most likely phenotype, and that would be our next. If that didn't come back, then we could go to something like whole exome sequencing, where we're trying to find a new gene. No question he has a retinal dystrophy. We need to find that. That may not explain it. He still could have two separate disorders. And I think for the time being, we have to consider that seriously and turn it over to see what JP thinks.
So I think, given the fact that we have no treatment for retinal dystrophies, you're actually hoping that these are two separate diseases, and then you try to treat the inflammatory component. Again, we don't know what that inflammatory component is. The differential diagnosis isn't that big for kids with inflammation like that if you think you've ruled out infection, and there's no evidence that this was an infectious etiology. You highlighted a few of those. This is not how HLA-B27 disease would obtain, so even if the B27 were positive, I wouldn't think that it's B27 associated. Maybe pediatric sarcoid, which is sort of difficult to diagnose. It often doesn't have the pulmonary findings that adults have with sarcoid, where 80 to 90% of patients with ocular sarcoid have an abnormal chest X-ray. I think it's reasonable to try to treat with an anti-inflammatory. You want to try to minimize toxicity because there's not, again, any clear evidence that what you're doing is going to help. But I think as I said, you're hoping that that there are two separate diseases, and then what you see here is treatable, that you could perhaps get him back to his baseline status.
JP, does the family history of sarcoid mean anything to you, number one? And number two, in pediatric sarcoid, one of the most common things is rash. He doesn't have rash to biopsy. There were some papers about transtracheal bronchoscopy or biopsy. The reason we went to a CT of his chest was because the family is because we wanted to make sure that wasn't it. It was negative. Any role in going down there bronchoscopically or otherwise to look for sarcoid more thoroughly?
Well, two answers. One, in terms of the familial history, there are some cases where sarcoid does run in families, so it's sort of interesting, but it doesn't do anything more than just make you say, that's interesting. In terms of a workup, I would sort of treat it like an adult. Bronchoscopy is not a benign procedure. And in an adult in whom I suspect sarcoid, in terms of the ocular inflammation, but who has no dramatic X-ray findings, either on CT scan or chest X-ray, and who has no pulmonary symptoms, I don't know if it's going to affect my treatment. I'm going to treat whether or not they've got a positive X-ray or a positive biopsy. And because I think there is a potential risk to those, I'd be very disinclined to do anything aggressive in terms of systemic invasive diagnostic testing.
All right, so moving forward, just in summary again, we have an 11-year-old male presenting with macular cysts, pigmentary changes, found to have non-leaking cysts by FA, as well as an abnormal field in ERG. He experiences transient improvement, is lost to follow-up, and presents with an apparent uveitis with minimal improvement thereafter with periocular steroid therapy. Genetic testing is currently unrevealing, so some questions yet to be answered. I will have to stay tuned perhaps for future Chiefs rounds. I'd like to thank...
Before you end, he was started on methotrexate.
He was initially started on methotrexate, yeah.
Just recently, and that's the next phase of treatment to see where we're going.
Great. Thanks, Dr. Levin. Dr. Dunn, thanks so much for helping me here. Appreciate it.